Um, Hi, I think we can start whenever you have quorum. There is not going to be an attending in the room because we are all scattered. Um, I am in scans, Huda is in service, and Whitney is in education somewhere. Yeah, she's at home. Are you
I'm at home
available
and
to?
traveling at one. Yeah, going to leadership conference
Oh, okay. But you will be available for the meeting for
till at least 11.
supervising?
Yeah, till 11. Yeah.
Okay, thank you so much for
Yeah, of course.
being here with us. So whenever Huda is ready, and who's the fellow in service, Sonia?
Me.
Okay.
Done.
I think Huda has to see a patient at 8 a.m. Did she tell you?
She did. I did just hear her a few minutes ago during OBCC online. I'm not sure.
Let me see. Oh, she's here.
I'm just logging on. Give me one sec. Recording in.
You're gonna have to call Cindy. Hi, so let's present something else, outpatient, and ultrasound first. And as soon as Huda joins after her genetic consult, we can review inpatient. She wants to be present to discuss her cases.
Okay, no problem.
Okay, I'm gonna need a few minutes to set up my ultrasound. We still have 7 minutes before 9. Give me 1 second. It's whatever yours is. Yes.
Whitney, did you present the cases with kidney problems last time?
Yeah, I presented the second one you mentioned, Amon. I didn't present the other one that you just sent me about last night, but I'll make sure to add her for next.
Hassan, I mean, there is one that had bilateral something. I still not
That one,
figuring out. Did you present that
yeah,
one?
I presented that one last week.
Yeah,
Yeah.
I still don't know what she has.
I think she has bilateral hydroureters, but I don't know why
They're so close together.
they are. Yeah, I mean, it could be like a weird horseshoe
Okay.
kidney is the other thing I thought of, but yeah, we did talk about her last week. And I'll talk about the
Okay.
other one you sent me next week.
Okay. I'll skip that one. Mm.
Is Kavisha in the room? No, Kavisha's online. Hey, Kavisha, what's the update on the patient with likely trisomy 18? I was gonna text you, but I could ask you.
1 second.
Okay.
Is that someone that was diagnosed in ultrasound?
Yeah. She was
Is it recent?
cystic hygroma, positive NIPT for T18 like 2 or 3 weeks ago. Last name Beam, Behm.
I don't remember her. I only have seen
I'm
one.
looking on the list to see.
I also have Epic up. I can look. I just thought it might be good for us to all talk about.
I have just 3 patients to touch on, but I can wait until after we do inpatient. They're quick updates. But you know that patient with the interstitial lung disease and scleroderma?
Yeah, what's the
We're
update there?
discussing azathioprine. They're going to discuss her either next Friday the 17th or the 24th. I said that was fine because she's only 20 weeks. But that's like when they have their whole division together.
Okay.
So
And
we'll
then
know.
they'll let us know, basically.
Yeah, I think they'll wind up recommending it, but I don't know if the patient will want to take it regardless. We'll see.
Looks like, yeah, and that patient that I mentioned with the T18 and the cystic hygroma is scheduled for an ultrasound tomorrow.
Okay.
Okay, hello. Okay. Thank you guys. All right. I'm getting an echo. Hold on. Is there an echo anymore?
If you have the computer, you have to mute it.
How about now? Okay, I don't think there's an echo anymore.
Yeah, it's good now.
Okay, give me 1 second. Okay, so this is a patient. This is Mia Scruggs. She's she's in her early 20s. She was a referral from Dr. Angarita, one of our old fellow at Jefferson Einstein Montgomery, for a second opinion on abnormal lower extremity findings. So let me go through kind of like the
Yeah, and if you hit that like double
so
screen.
just kind of go through the normal first, left angle, everything looks normal. On the right angle, let me play a clip.
Yeah.
How do I? Sorry, bear with me. First time using AS remote. Okay. So as you can see here, and this case, it reminds us a lot of the case that Dr. Bender presented last week. So typically in a sagittal view, of the tip fib. Oh, I think we missed it now. Sorry, I'm getting.
Hi. Can you hear us now?
For the sagittal view of the tip fib, normally we should be seeing a right angle, demonstrating a normal angle. I'm going to play this clip again. There's a few more images. So as you can see here, we agree with the outside referring hospital that this patient have a right club foot. And one other thing that we found on our ultrasound at the time also is an absence of either the tibia or the fibula. In this case, we're suspecting the one bone that was present in the leg is most likely the tibia. Just the overall incidence. Here, there's a nice clip here. As you can see, just the one bone is present in this lower leg. So this patient, was discussed that this finding is most likely sporadic. And she has a lower NIPT. There's no other history of any family orthopedic issues. So she was referred to further genetic counseling to talk about diagnostic testing, but also orthopedics, pediatric orthopedics, to further discuss management of postnatal. So here again, I think it's pretty significant that you guys can see here. So when we look into this condition, it's called hemimelia. There's a wide spectrum of presentation. You can have partial hemimelia where only part of the tibia is formed. In some cases, the fibula is completely absent, which is what we see in this case. It's hard to really differentiate whether the bone that we're seeing is the tip or the fib, but most likely in the literature it's the tip that's present.
Hi, guys.
Small bone that is absent. Hi. We're talking about clubfoots with an absent fibula.
You said
What?
Fibula.
Oh, fibula. Oh, yeah, the one that Dr. Bender presented the other week.
Yeah, so very interesting to kind of see similar case back to back.
you have an echo and it's very difficult to hear.
Dr. Roman, all of our computers are on mute. The only sound we have is from the computer. I'm not sure why it's still echoing.
Is anyone?
No one
No.
else is doing it.
No one is on their phone.
I mean, I'm mute. I'm mute here too. What's this Zoom here? Where is this Zoom thing? It's not.
It's not only that you need to be muted, it's that your computer needs to have
Sorry,
its
what?
off.
Someone is presenting here. I use Zoom right now here. Yeah. How do you see the settings of the Zoom? Like,
Someone is presenting an entire thing.
wait, I just presented this.
Someone is talking in the background. Oh, it's that. Oh. Okay, got it. Okay.
Okay, you guys have to put this up on your.
Do we have any more echo? I don't hear any more echo.
I think we don't have an echo. I thought the echo was there, so it's the other group.
I think the actual echo is gone too.
The sound should come through the.
There's still an echo.
Oh, they can't hear us.
Oh, they can't hear us still.
Oh, okay.
Why is it messy this morning? This is because. Did they do any changes?
Think so. No, we went through OVCC fine though.
Oh, MCC was fine. Yes, absolutely. Yeah.
Right here, can you see it going up? Right here. Do you see it going up on the thing? Yen is sharing AS from her laptop. If I turn the computer sound all the way off, we can't hear you guys.
Oh.
But if I turn it up, we have an echo, which I've never had before. We didn't just have it during.
Okay, we're holding up. No ED phone calls so far. Okay, that's good. Well, I'm gonna be doing my exercises. And nice to meet you.
Nice to meet
I'm
you.
from Lebanon.
Oh, أنا كمان.
أهلا وسهلا.
أمي وبني. Different.
Okay, that's good. Are you gonna be doing? I got your schedule.
I'm doing outpatient.
Okay, that's fine. Okay, I'm gonna be doing my exercises. Don't you guys get mad, okay? So the other people don't hear me.
You know what I have at home that my mom sent me? God.
Onions.
Okay.
I'll bring some. Oh,
I have some.
oh, you have some?
I am unmute. You think it's me or should I just log out? Okay.
Hello? Can you turn your sound on your computer?
Hello? You mean unmute? Okay. Okay, can you guys hear me okay?
Can you guys hear me?
Oh, yes.
Okay. Does anyone else still hear an echo?
1 second. Stay with me, Sage. We're coming. What do you need?
I think it sounds okay. Yan, can you say something else?
Yeah, can you guys
Yeah.
Okay, so right now,
Yeah.
Everyone can hear us and we can hear you, yeah?
so now we're unmute there and
Yeah,
we're
just use Yen's computer as the one source of in and out audio.
okay. I mean, we
Okay.
have a small audience today, so I think maybe my laptops.
Okay, Sonia, I'm hanging up.
Okay, so well, that's my one ultrasound case. Pretty interesting. I'll keep everyone updates. Patient might not follow up here.
Yeah, just Yen mentioned this, but it's so interesting that we had 2 of these cases in the last like 2 weeks. I had never seen this before. So, differences between Yen's case and my case. My tibia was short, relatively speaking, so less than the 10th percentile. This one eyeballs at normal, but I don't know if you guys measured it to see if it was short. 11.
Yeah.
Okay.
Yeah. It was like I think 0.7 centimeter, a bit shorter than the other side, but it can also be, error of measuring. It doesn't seem significantly shorter, and the baby was noted to be moving the leg normal.
Probably also should use the fib. It's because it's the tib, not the fib.
Yeah, it was me measuring.
That's okay. No, we could always change it on the back end in the report. But this tib is also not bowed. Remember the one that I showed you guys was really bowed. And then varying degrees of whether or not there's any fibula present. So for both mine and Yen's case, no fibula, and then varying degrees of ankle abnormalities. So Yen's ankle is clubbed, right? See the plantar surface of the foot. My ankle was like extended, but also had an abnormal number of metatarsals. I don't know, again, as far as you guys could tell, the foot looked like it had the normal amount of bones, I think.
Yes.
Yeah.
Yeah.
I think, postnatally, obviously imaging with x-ray to determine, the severity of the condition and next steps. But like we talked about last week, it's really two options for treatment. One is amputation in the first year of life, and the other is serial leg lengthening procedures to make up for limb length discrepancies. And in terms of long-term outcomes, seems like amputation is probably better tolerated by patients and parents. But obviously a very difficult decision for any parent to make in the first year of a baby's life. But yeah, so interesting that there's been two. I'm sure there'll be one more now. We'll be ready.
Oh, is this the second case with absent fibula?
Yeah.
Oh my God. Okay. What's going on exposure-wise now?
Probably Tylenol.
No, it's not Tylenol.
I'm just a little humor. Nobody take that anywhere.
I know. I love your humor. Okay. Shall we move to inpatients now? Sonia? Dr. Sanchez and Sonia are going to present our inpatients. Okay. We have very amazing MFM service that's great for the fellows teaching today.
I'm a third year outside resident rotating in the MFM rotation. I'm gonna go and discuss the inpatient service. First, we have Matthew. She's a 37-year-old G5P4, 15 weeks and 3 days. That came in yesterday by the ED and active withdrawal. She was stated by the ED by a 15-2-day ultrasound. This was a bedside. For her overnight event treatment in the ED, she was hypertensive to the 170s, 180s. She's on clonidine patch, and she had to use dilated 4 milligrams Q2 and President's DTT. To talk about her active withdrawal, her toxicology screen was positive for amphetamines, benzodiazepines, opioids, fentanyl, and cannabinoids. She was hypertensive up to the 200, and her CAL score were around 27. She is currently on the ICU care and is unable to answer any questions. For this pregnancy, she had her first pregnancy test for review back in 08-06, no prenatal care, and the baby was based on the ED. For plan for her, we're just awaiting her to be a little bit more stable and out of the ICU care to assess if she would like to start any MAT therapy.
And then just from chart stocking, it sounds like she's had multiple admissions at outside hospitals and expressed a desire for termination. So once we're able to talk to her, we'll readdress that.
For our second patient, Alvarado, she's a 23-year-old G2P1001 that presented for an outside hospital for evaluation, surgical evaluation in the setting of a hepatic adenoma. For overnight events for her, and her vital signs also are stable. She was dated by a 6 weeks and 2 day ultrasound. To talk a little bit more about that liver mass, she had an MRI that showed a 9 centimeter caudate lobe. That's how they were kind of like characterizing it, but then an ultrasound, it seems that she has a 10 centimeter epigastric mass that has a different attenuation to the liver parenchyma with concern of hepatic adenoma. Because of this, transplant surgery was consulted, and IR. For transplant recommendations, they prefer IR embolization first and see how she reacts. IR, it's going to have an embolization that's going to be tomorrow.
So there's been a lot of back and forth between our team, transplant surgery, and then IR. Because this liver mass is greater than 5 centimeters, it's at a really high risk for a rupture. We discuss a transplant team, and we were hoping that they would consider surgical management. I think right now they are concerned about this large surgery, given that she is pregnant. So their plan right now is to do, like Andrea mentioned on Friday, an embolization. They will then perform serial imaging to see if this mass is shrinking in size. They are not able to tell us like what their parameters are on like an appropriate amount of shrinkage, but our plan is we're just going to keep her inpatient, do the serial imaging, and then go from there.
Do they have an idea, Yen, or sorry, not Yen, Sonia, about when you would expect to see any shrinking from an embolization and sort of like the time course of how long she might be here while we're looking for that?
Yeah, so he said 3 weeks, but I have to share with you some information. So when I took service Monday, there was this meeting at 8 o'clock we went to. So I asked the same person, what's the chance that this is gonna shrink with embolization? So his immediate response, this is the hepatology transplant person, is like, it's slow. I'm like, if it's slow, why are we even doing it? So I think everybody is good on the surgery. That hepatoma is adjacent to the big blood vessels that she has. But I have to make sure everybody is aware. This is a patient who's been having abdominal pain here for 4 to 6 weeks before she came over. It's so sad. And she's been having nausea every time she eats. She's lost almost 18 pounds in pregnancy. So, I have multiple other factors here that are telling me really we need definitive treatment. So I spoke face to face with the same transplant hepatology yesterday. And apparently the IR person convinced him there's going to be a higher chance that it may actually involute after embolization. According to him, I told him what's the percentage. They do have data, but again, it's small series. Problem with reporting, publication bias. It's maybe 50%. And I told him with the embolization, make your surgical excision much difficult, and 28 weeks is much harder than having to do the surgery at 24 weeks. And just for the fellows to know, Lachey was here almost 2 years ago, and Dr. Oman worked with Lachey on an amazing hepatoma presentation, which we actually used, in order to educate us again, and share the wealth of knowledge with so many other people. And we also sent an updated paper on Sunday. So this is a fascinating case. Why I cannot send this patient home? She lives in New Pennsylvania. And when she went to Penn State, I spoke with her MFM, long conversation like 2 nights ago. Apparently, when she went there, even though they have 8 MFMs, the liver group were like, let's just wait 2 to 3 weeks and repeat the imaging. So basically, she's the one who advocated that her patient needs treatment because if this ruptures during pregnancy, there's like a 40% chance they may die. So we are all on the same page that this patient needs treatment. So the question here is, which I discussed with Dr. Shah, is probably she's going to have to stay inpatient, for us to observe her, after the embolization. I'm not sure. I think by next week we'll have more information if we're getting the embolization done tomorrow. So, but that's the possibility because she told me upfront, the group there was like reluctant, to treat her basically in pregnancy.
Yeah,
Basically she's ours now. She's ours.
Yeah, I'm glad that you brought up where she lives, Huda, because I was going to say the same thing. Like, unless she gets a definitive surgical procedure, which it sounds like, we're not doing at this point, she can't leave because she will die if she ruptures in the middle of where she lives, so she may be here for a very long time if we only maybe here till the end of the pregnancy even, which is unfortunate for a number of reasons.
Yeah, and I told Dr. Shah the same reason. I'm like, my God, I wish you can do surgery on her now because this is what she needs. Given, you have to think about the social and geographic needs for all our patients. Okay. Okay. So we finished this patient. Did we also say the baby was FGR 8%?
She was just about to.
Oh, okay. Okay. So we have other issues on her. The baby is FGR. Otherwise, she's really lovely. Her entire family is involved in her care. Her mom, dad, aunts. Okay, great.
All right. And then earlier in the weekend, we didn't have access to her dating ultrasounds. This patient has not had formal prenatal care We were able, or Andrea worked really hard, and she was able to find a 6-week ultrasound. So she is still growth restricted with abnormal Dopplers. We extensively counseled the patient on, potential outcomes of this pregnancy, and both she and her family are all on the same page that they want to do whatever it takes to, take care of her health. So right now we're prioritizing maternal health.
Yeah.
All right.
Okay. For our next patient, Erasmo, she is a 34-year-old G3P2602. She's 32 and 2. She has a diabetic twin pregnancy that came in first for evaluation after MBA and staying patient in the setting of elevated LFTs. For her, she did not have any overnight events, and her vital signs remain stable. For her MBA, she's stable from that standpoint. She was cleared by trauma, and there's no concerns in that standpoint. For transaminitis, it was seen just on laboratory work, and she was normal. She had a 14 to 11 on the night too. Currently, her last ASC ALT is 66, 135. That's actually the first day that it's less or stable from before. She has no signs or symptoms from this. We did a workup that included an hepatic panel, right upper quadrant ultrasound that was negative. We also included CMV, IgG, and IgM. She was IgG positive or IgM negative, and the PCR just to rule out any type of preeclampsia or anything. Her urine was 0.20. Because of the persistence of the transaminitis, she's currently undergoing a 24-hour urine screening. Of this, her blood pressures have remained completely stable. We also included a bile acid level that is pending the result. This pregnancy is also complicated by GDMA1. We have been just doing blood glucose tests for her. She, in the setting of the MPA, did receive beta. So we added a sliding scale for her. It's well controlled. She only received 2 units of Lispro overnight, and her fasting was 102, very well controlled.
Okay.
For her,
Yeah. I just want to make sure, Amanda and Whitney, are you okay if I discharge her today? I know her allergies are like 135, but
They're stable.
they were 11 and 14.
Yeah.
So, we were planning for a possible discharge with going to the office, maybe getting blood pressure checks or getting a blood pressure at home, and then maybe weekly CMPs just for follow-up.
I don't know, twice weekly CMP, twice weekly NSCs. So
And we don't have an etiology still. We don't know what, like, did GI see her?
No, she's asymptomatic. Her gallbladder.
And they're resolved. Sorry, they're still elevated or they're normal now?
No, they keep sending, today maybe it's stable 135, but then, every day they were increasing a little bit. Her gallbladder ultrasound was normal, to be honest.
Yeah.
I have to have panel. So basically, I always, CMV, we did AGG, IgM negative. So atypical health is always in my brain. And she's Spanish speaking. Hopefully she'll be compliant in her curve. So that's why I feel I'm okay discharging her. We'll do twice weekly anesthesia for her with blood pressure checks, and then twice weekly labs. And basically,
is there any benefit in doing any other workup, like other lab? I mean, it's a little bit, strange that this happened right after an MBA. Like, one, any chance this could be from the MBA? She did hit her belly. 2, any chance that there's something else that we're like missing that we haven't sent, like, autoimmune conditions, other like things. I don't disagree with discharging her. I'm just wondering if her workup is done.
Yeah.
Wait, it says in the handout that she has itchy palms and soles.
yeah, that just needs to be updated.
Okay.
That it's not like cholestasis.
Okay.
Yeah.
So you will get GI with me? GI?
I would, just to make sure that they don't, like, one, I guess my question is, could this be from trauma? And 2, and they might not be able to say that. And 2, like, is there any other workup that they'd recommend before discharge?
So I'm gonna be honest, the reason I ordered the allergies when I took over Monday is because she had a site with the twins. So that's why we did them. And September 2nd, they were normal. I'm not sure why they were ordered September 2nd. So, but they were like 50s. But then they kept tenting, and this is way after the accident.
Yeah, just strange.
Which is Monday, Tuesday, Wednesday, Thursday, yeah.
Okay. For her twins, there are both cephalic, normally grown, and no concerns from that standpoint. Our next patient, Beverly, she's a 23-year-old G4P1021. She is 23 and 5. She peaked from a 23 and 3. She was transferred from an outside hospital here. She first was in labor hold, where she received a bolus of MAC, 6 gram, and then continued on MAC. She's currently off that. She also received beta 1 and 2 and is currently on day 3 of latency antibiotics. She got some swabs that everything came back negative, but the vaginitis spirula came back with yeast, and that was already treated. For her white blood cell count, it kind of like had a bump. When she was first admitted at the outside hospital, her white blood cell count was 6.9, and it came up all the way to 18, and this one is 17.7. The discussion was made about maybe this was about betamethasone, but in the setting of PPROM, we were concerned that this might be a chorea, so we're closely following that up. Right now, she has enough fibrils, vitals have been stable. We're just cautiously following up with expected management.
So she was initially transferred from Cooper with preterm labor. Upon a speculum exam, she was ruptured during the speculum exam. So presented with preterm labor, now with PPROM. So we have her on latency antibiotics. She's status post to steroids and received a course of magnesium. So we're just continuing expectant management until we see signs of infection. Like Andrea said, her white count has continued to trend up, but she doesn't have any fundal tenderness right now, so that's why we're continuing to watch her.
Yeah, and I just want to make one teaching point for the fellows. If you have a patient who's transferred from another institution for a large bulging bag in the vagina, please do not go ahead and put the speculum there. You know, we were not told that we ruptured her. We walked to the home to assess her, Monday, whenever she was there. And, I'm talking to the mom until, you came, labor, ruptured. She's like, you guys, the doctors ruptured my daughter's bag. So, and I was raising eyebrows being Sonia. So apparently, when you have somebody like that, please, this is not a case for the junior resident to go ahead and put the speculum in. All of us have to learn, but you can also do, an assessment with your hand, see what the bag is before you just, insert a speculum in, because, she may have been packing for a day or two more. And it's much easier for us to deal with it, from all perspectives, if she ruptures on her own and not iatrogenically by us. We know she was going to, right? So, but it's different when, yeah.
The other thing I would say is this is also an opportunity to look at, cervical dilation via ultrasound, like abdominal ultrasound or transperineal ultrasound, to get an idea of how much bag is in the vagina and how dilated they are above the bag, rather than a speculum or a digital exam.
Yeah, and also when you know how to do it, please teach the residents, please teach your junior fellow how to do a transperineal ultrasound. That gives a lot of information without doing in speculum.
Yeah, but also using our clinical sense. I'm not there at 5 o'clock in the morning. This is what happened at like 6 o'clock before we arrived. So I talked to the team, different team members. I'm like, you have to be careful. You know what we do in medicine. Do no harm, right? It's number one. Okay, great.
For baby that is normally we did a growth ultrasound here, cephalic, and the fetal heart rate and support which organizational needs.
Can we present our 6th patient on the 5th floor? Since I have Amanda and Whitney, I need you for the most sickest and most interesting case we have, because I'm scared you guys are gonna get busy soon.
Okay, she's a 39-year-old G1P0 at 17 and 3 days today. That comes in. We came in from an outside hospital in the setting of chronic hypertension versus a hypertensive urgency. Her blood pressures in the outside hospital were in the 200, 190s persistently. It seems like they started to treat her, but were unable to stabilize her, and that's why she was transferred to here. Here, on admission, her blood pressures were very high in the 190s, 180s. She declines any history of chronic hypertension prior to pregnancy. She was started on the outside hospital for cardia and levodopa, but it seems like she was not really receiving them in the setting of nausea, uncontrolled nausea, and vomiting with pregnancy. Here, she's currently on nifedipine 60 BIG and levodopa 400 TID. She did require some multiple pushes when she first arrived, but the last push that we have to give her medication was in the 7th, and none
And she required so many IV pushes that she almost needed to be admitted to the NICU to control her blood pressures, and ultimately
For IV medication.
yeah, and ultimately while waiting for a bed, her blood pressures were improved, and that's why she was able to stay on her service.
As part of the workup that included a TETE that had an EF of 55 to 60% with moderate hypertrophy of the left ventricle. We also had a renal artery ultrasound that was negative. We had a BNP that was 327, and all the health labs were normal, but an elevator creatinine, her baseline is 0.8. And when she first came in, her creatinine was 1.38. Her EKG was normal, her chest x-ray was normal. We just completed her 24-hour urine screening that came back at 2:30 this morning. And her labs other than the creatinine and the calcium have been pretty stable. On admission, she did receive magnesium 1 gram per hour given her creatinine, but that has since been stopped. She has a card consult in place, which they recommend blood pressure in all 4 limbs just to see for coarctation that was within normal limits. We also updated RAS level that we're still waiting for the results, and the nocturnal pulse ox measurements were with our normal limits. The 24-hour urine measurement readings also were ordered, and we're still waiting for that. So because of the elevator creatinine, she was diagnosed with acute kidney injury. We consulted nephro 2, which they recommended some vitamin D levels and PTHRP. She also had this hypercalcemia. On presentation, that's a little bit better now, but they were concerned that this might be some kind of dehydration standpoint. She was put in IV fluids. The hypercalcemia is still there, but it's a little bit better today. But the concern was too that this might be also in the setting of a maybe malignancy and lytic lesions. Just something that we just have to consider. For her uterus, so she first came in for the hypertension.
So I think the most important part here, after Dr. Sanchez, is to show you the images. This is a baby who almost had no fluid at 17 weeks. And basically you should see, you can't even feel the cervix according to Victoria Diamond. The pelvis is full of masses. We think fibroids, but it can also be pelvic masses associated with malignancy. So as Sonia is pulling this out, but I also have to share with you that this is a patient who does not trust doctors. So she thinks her problems are because she's here with us. So I'm very much worried about this patient, whether this is, gliomas that are associated with cancer, like what is here. You could see how the scalp of the baby. Go ahead, Sonia, you take it.
Yeah, so here you can see a very large fibroid. They're measuring this about 19 centimeters. There's also some cystic structures as well, which they're also calling fibroids. And then I'm trying to get to the part with so up here, you can see this is where the baby is. So the baby is extremely compressed. You can see that the skull is also compressed. There's minimal fluid, so anhydramnios.
Can you freeze this picture here? Can you go back?
Any chance that this is a twin pregnancy and there's that rapidly expanding thing is molar?
It can be also, absolutely, yes.
We got it.
Yeah. We got the data SCG and it was 64,000.
So a little low, but I mean, those aren't normal fibroids.
Mm-hmm.
And it would track with this hypertension picture.
Fibroid with calcifications and cystic degeneration, which is common for fibroids that are this large. Did she rupture membranes?
She doesn't complain of leakage of fluid.
But there is no fluid.
I know. So I
Do
think.
you see any fluid somewhere?
We did another bedside ultrasound yesterday, and I could see a little bit more fluid, but it was definitely still anhydramnios.
Is this baby growing on track with her updates?
So we have not done a growth ultrasound. We did not do a formal growth yet. Yeah.
I mean, because if the alternative diagnosis to, why there's oligoria and hydramnios is that this is just pre-viable preeclampsia with terrible, placental function.
Mm-hmm. We extensively counseled the patient, both on admission and then yesterday regarding, the different etiologies, and our recommendation for termination. The patient is not really willing to speak with us or, discuss how she would like to move forward. She, at this point, wants to leave and discuss with her family. Yesterday, we did not feel comfortable sending her home given how severe her blood pressures were upon admission. And we've also been coordinating a lot with Dr. Banekar because she is the one who is being involved if this patient did undergo a termination. So right now, we don't really have a plan.
I have some concerns about her undergoing a termination even. Can you
Yeah.
access the canal? Because it seems like there's no regular cervical architecture or anatomy. And then are the instruments long enough is another one. If she terminates, she may need a hysterotomy, and I am concerned that this uterus can't be put back together safely, and that's gonna end in a hysterectomy.
Exactly. Yeah, we've been talking.
And so she should not be brought to the OR without oncology there, I think.
Correct, absolutely. So I've been itching to call them since yesterday, but we were waiting for the MRI, which she went last night, but she was moving because she's not listening. And Sam is going to present her to take the pre-op. So just to give you a heads up, Gavita doesn't think anything can be done to the vagina. She thinks if the baby is to be taken out, it's going to be by laparotomy. Now, I need the consensus for everyone. If she wants to go home, I want to sign against medical advice paperwork with her. Are you okay with that?
100%. I would not discharge this woman.
Because she told me I need second opinion. I told her I'm more than happy to help coordinate. You tell me which hospital you want to go to, and I'll call the doctor still. And I'll send you by ambulance.
Yeah, there's not a lot of places that are going to be equipped to accept her. But
do we have any ultrasounds prior to pregnancy just to get a sense of like?
Did she get?
I was just looking. There's one from June of 2023, and it looks like there were fibroids, but they were a lot smaller. Like also the rapid.
Well, that's what I'm like. Is this a leiomyosarcoma?
Yeah,
That's not, and even like the ultrasound imaging is sort of concerning for that too, given the size, but also the echo texture.
I absolutely agree. I feel like that.
I tried to get the NIPT, and the NIPT done at 1,000,001. They couldn't do it.
Huh.
That's the thing. So I had Alexa call the person, and we got a very detailed message, which probably we're gonna have to include in our notes, Sonia, that the results for the NIPT are actually messy, involving multiple things. So that's why my number one diagnosis is malignancy on this patient. But I share this with her. But then it's so interesting because William and one said, well, if you want to repeat it, maybe laptop is good for these cases. So this tells me as this is a lab I never want to work with.
Sonia, did the MRI image her liver at all?
I'm sorry?
The liver is not commented on in the MRI. Did it go up to the liver? Because if you're gonna have a metastasis in leiomyosarc, you'll likely see it there.
I hope they should do the liver.
So this just looks
commented on. It might just be the pelvis.
Yeah.
This looks huge.
And also the irregularity of a border fibroid, not distinct entities. I think this MRIs help us appreciate this mass more.
Yeah.
That's
and then we're going to have, you said Sam is presenting at pre-op conference. So I'm assuming Dr. Rosenblum will be there, and same thing with like Dr. Kelly, and I forgot who the new attending is, but I just think GYN oncology, not just for surgical management, but for like malignancy concern should be there.
Yeah, I think this patient, if she is gonna go to the OR, it's gonna be oncology. This is, and we counseled her to be honest for termination just because of the anhydonias with the hypertensive crisis, the acute kidney injury, the left ventricular hypertrophy. But she said, when she said that she didn't trust us, and then I asked her, sure, because you trust the superpower of God. She's like, no, I trust my culture. So that's why I need to go home, meet with my family. And, you go into the home, and she's like huffing and puffing, like, what are these people doing here? So I think in our documentation, we do need to start saying that she's unhappy seeing us. You understand me?
Sorry, if this was already addressed, two more things. Her hemoglobin being 8.7 in anticipation of needing a very bloody, potentially surgery.
I am already on it.
Okay, and then her platelets are also trending down.
Yeah, they were 143 this morning.
How much?
It's 143. So like
They're just drifting. They're drifting.
17. Okay.
I need to just today. That's how much were they before?
Pull them up here.
173 yesterday. And
So
I
that's
think it's
significant.
189.
So that's a significant decrease. Right? From 189 to 143 on someone with high blood pressures on high dose blood medications. You know?
Anhydramnios.
With anhydramnios. Yeah.
Yeah. You
This
know,
is a mess.
did we get, I know it's a mess. I know. Thank you, St. Mary's, yes. Did you get just X-ray for her?
Yes.
Okay, it was negative.
Listen, is there utility in CT chest? If we're worried about, I don't know, maybe you can
I
ask
feel
on.
like if the chest X-ray was negative, no.
It's for her because she just refuses, so we're just focusing on what we need.
Yeah.
So my lawyer is, we go today to see her, and she's like, I'm going home. You understand me? And then, it's gonna be a big fight with us. We're gonna tell her it's your best interest to stay here, but if she doesn't want to stay, what am I gonna do, correct?
I mean, I think you could, as you said, Huda, offer to transfer her to a different hospital for another opinion. Penn will hate us for doing that, but we could try to do that if she wanted that. And if she is not willing to do that and not willing to stay, then you have to make her sign out AMA.
Yeah. Can you view the images, because I don't want my colleagues to go? Do you think really that tutors could be the second? My thing is, this is huge like that. And, even if there's a motor, I think the motor is a tiny bit probably involved there, but it's really difficult to delineate anything there. Maybe we'll put one image at a time in this slide.
Yeah, I mean, I think it's really hard. I don't see anything that's like classic snowstorm per se, but there's also like clearly a mass that has a lot of like hypoechoic spaces in it. And I think that has to be on the differential.
Yeah.
Especially given the hypertension and the gestational age that we're at.
I think that we did the AFP on her, it was 126, not the MSAFP, the AFP, is that high for people?
I mean, it's unreliable to
Yeah,
check in
I understand, but
pregnancy.
what's the normal age for non-pregnancy? We can discuss that later, but this is the thinking. Beta ICG was fine, her LFTs had been okay, so this is the picture, go back to that one. The picture with the two cystic structures there. This is here where I get concerned, is this a gestational sac? You understand me? But then I'm like, I don't know where the cervix is, all of these things. Yeah.
Does she have known fibroids or anything?
Yes,
No.
yes.
Grown inside.
So I don't know
23.
strategies for this patient. Like, I don't know what to do to make her like us, Even though we're not on our knees for her. And she doesn't like many people in
Is it
her home,
rapidly enlarging fibroid?
Yeah.
Because
I think that there is like truly this is tragic. There is no easy way out of this. And everyone will tell her that, and she will likely be angry for a long time. And eventually this is gonna resolve in a very morbid way. And it's just really sad.
She's gonna die at home.
Resolve or she'll die. Yeah.
Correct.
It's either gonna resolve or she'll die.
Yeah.
Do you think we can tell her you may die?
Oh,
100%. I think we have to tell her.
Class, not from the hypertension now.
It's all of the whole.
I mean, it's the entire picture. Yeah.
Whole picture.
I'm gonna focus this discussion. And then
Fetus is at a high risk of intrauterine demise. That there's no way for it to come out. That's going to lead to sepsis in her if she doesn't die of her hypertensive urgency and a stroke before that. If she presents for a resolution of the pregnancy in some way, it can't be accomplished through the vagina. If it's accomplished through the abdomen, she's going to lose her uterus. This might be cancer. And that is going to lead to an insane amount of blood loss in an already anemic person who might also be thrombocytopenic significantly when she represents.
Okay.
Like her risk of mortality is high.
The basics going down now to 143, so now I'm getting more nervous, and I don't want people to operate on this one on the weekend.
Also, a formal on-consult?
Yes.
And formal oncology.
Like not pre-op, but like a formal.
I didn't want to call them, Monday, Tuesday, when we didn't have the MRI. We got it last night.
So I did counsel her yesterday about the significance of these findings, how it could be a malignancy, and how we are concerned for her life, including the risks, and I did include death. I think the issue that we are having right now is she is so distrustful. She's not accepting of that, and she's not willing to discuss next steps in management. So we can definitely get
find
people on
another
board.
place to
Yeah,
go.
yeah.
Maybe I'll send her back to Penn State with me where I got the other patient.
Yeah, I think that's a fair trade.
Okay.
I mean, honestly, I hope that we get some answers on her because I think it will be really interesting to see what is in her uterus. I just hope that we get to do it while she's alive.
Mm-hmm.
I know. So I think I have to go meet with the audiology this afternoon. Everybody agrees? Okay, good.
Hi, I just wanted to mention for this patient that Dr. Jones had reached out to us to schedule her in cardio B for a few weeks. I don't know if should I cancel that appointment?
I mean, you could schedule it, but we have no idea what her trajectory is, but she can hold a spot for now.
Got it. Okay, thank you.
Dr. Quali, I think it might be helpful to actually go to radiology with the onco team.
We're gonna go Rosenblum today.
Yeah, I think it would be helpful to kind of coordinate it that way where you have both teams together instead of separately, because otherwise Norm is going to go by himself and we'll have a conversation and then you'll have a separate conversation. And I think it'll just be better to go because he always reviews images with radiology.
Yeah, I'm texting him now.
My good friend who's a third-year fellow at IU had a very similar case to this last month, almost identical, except the patient, she also presented with oligohydramnios. She also had severe range blood pressures. She was admitted. She was actually sectioned at 22 weeks for hemorrhage. So she just started bleeding into the bed on an overnight call shift. Luckily, oncology had been made aware of her. She had had a pelvic MRI, abdominal MRI before this, whole abdomen filled with what looked like terrible fibroid burden. She wound up getting the baby didn't survive, no surprise. She wound up getting a hysterectomy on a weekend. They saw like peritoneal implants everywhere throughout the abdomen, thought it was cancerous. Thankfully, like all of the oncologists were there to aid in the case, and the path actually came back as benign disseminated peritoneal leiomyosis. So,
Peritoneal
benign disseminated peritoneal leiomyomatosis.
Yep, I've had these. Yep.
Yeah. But seriously, like an identical case, except just a couple weeks different. But yeah, she lost her uterus. There was nothing to put back together.
Yeah.
Was there any explanation for the hypertension, like a paraneoplastic syndrome or something? I know it's benign, but it's just the hypertension doesn't really make sense.
She's probably chronic because she has LVH. Her baseline was 0.9. It's funny because her PTH is low and her calcium is high, so I was thinking paraneoplastic neoplasm also causing her calcium to be high. So metanophins are pending, I think, on her urine.
Yes, we have all of those labs pending. The patient denies a history of chronic hypertension, but I looked back very far and she has definitely had mild range pressure. So this patient does have.
No. She's interesting how she answered that question. Actually, when you ask her, do you have chronic hypertension? And she's like, no, I have to answer that. And she answered it in a way that you wouldn't understand if she was hypertensive before the pregnancy. It's because, again, there's no test, so she didn't want to provide this information for us. Okay. Can you make sure we have reaching for 2023 for the fibroid size compared to now? Thanks. Okay. I'm so happy that we discussed this case with you guys. So it's going to be interesting to be determined. But Kavita Binekar, GYN was very much worried about her.
And I've been chatting with Dr. Binekar every day, but this patient has been here and keeping her in the loop. So she is very involved with this case as well. And case determination is what we end up doing.
Our next last patient.
So Our last patient is also another interesting patient. She is a 4-year-old G6P2113. She's 35 weeks and 4 days, and she is admitted with fetal atrial flutter. So this patient was seen in New Jersey, and she was sent to us earlier this week. On admission, this baby had heart rates in the 220s to 230s. So we have been co-managing her with pediatric cardiology as well as adult cardiology. We started her on digoxin. So she's received now three loading doses of digoxin and is currently on 375 micrograms BID. We've been obtaining digoxin levels, which so far have been therapeutic. Her most recent one from last night was 1.0, and then there was one pending for this morning as well. Shuvi has been helping us with this case, and she has been aware of her dose. Throughout the patient's stay, there has been periods where the baby does come down to a normal heart rate, but it's still persistently elevated. So our plan is that we're going to add flecainide if later this afternoon the baby has not completely cardioverted. Otherwise, from like a maternal standpoint, mom is currently on continuous tele. We have been doing EKGs and we've been monitoring her CMP for electrolytes and have been repeating as needed. And then otherwise, she's obese, but there's no other major complications this pregnancy. Does anyone have any questions about her? We've been doing daily ultrasounds as well.
For the fellows, I really want you to look at the anesthesia for this patient. That's the best part for you to learn. And to see how you go from 220, now that the baby is starting to cardiovert, you go 220 and then 160, 160, and then.
God.
So, and typically what we do is we do calculations for percentages, like how, in algorithm, what's the percentage the baby is in algorithm. So just, I don't think we can pull the tasting, but for your teaching, you need, hopefully, if you can pull the fetal heart rate, that would be excellent.
And we've been doing daily ultrasounds for this patient. Our sonographers have been great and have been coming over to do a quick echo. On admission, we did not see a pericardial effusion. Yesterday, there was a measurement of 2.2 millimeters, so borderline. So we'll continue doing daily ultrasounds and continue to monitor the baby.
Sonia, it's Alexa. Is this the patient that was referred from St. Chris Cardiology?
Oh, Alexa? I don't think I got the official echo.
We have like a hand.
Alexa, can you reach the cardiologist? I talked to Sandhu. Can you please reach out to them? I need the official echo report. I want to see.
Yeah, the nurse from St. Chris, the fetal center, she was asking if someone could call her with an update on this patient that she could relay to the cardiologist.
But I need that cardiologist official report. I want to see if that baby had tiny pericardial effusion, because now we saw a tiny pericardial effusion yesterday. All what I have is a handwritten something from the cardiologist.
Okay, I can ask her for the report. It wasn't in Care Everywhere? I thought that I saw it in Care Everywhere under St. Chris or Tower Health.
Okay, we'll check.
But can someone, I'll message you, Sonia, to give you the number to the fetal nurse at St. Chris.
That sounds good.
Okay, thanks.
Okay, that's good. I think this is all the inpatients. Okay, good.
What a service. You guys are busy. Sick people.
It's a beautiful MFM service, right? Yeah. So Don Rosenblum already texted me that the new attending woman is going to be seeing the patient. I is the chief for the patient.
This way I can sit on a chair that has some armrests for my arms.
Oh,
there's no chair here that has armrests. This is crazy.
Yeah.
You good?
Yes.
Okay.
Anybody have questions regarding the inpatients, or what would you like us to do next?
Journal club?
Oh, we don't have clinical cases?
We don't have, do you have,
I just
you have two more.
Really quick to discuss, super fast.
Yeah, go ahead, Sophie.
There's I think they're both on the MFM continuity analysis. Let me just pull it up. There's a newly diagnosed vasa previa. Where is she? I presented her on the continuity list.
I'm gonna be on the
Caitlin Cleaver. She's a 35-year-old G1 P0. We talked about her. She like transferred from Axia on the Jersey Shore. I forget what hospital it's called. She has no history of preterm delivery. We saw her yesterday for a consult. She is a type 2. She's not interested in ablation. We were just discussing when to recommend admission for her. The one thing I need is her ultrasound imaging. I think I talked to Steph and Melissa yesterday about getting that from her prenatal records, to see if she had any like cervical length measurement at her anatomy ultrasound. We saw her for her first ultrasound, really for a second opinion, on the 26th of September, and she was 23 and 5 at that time. And we just confirmed vasa previa, counseled her as such. She really has no other complications except for AMA with a low risk NIPT. She's put her prenatal labs via like a screenshot in the media. Don't have any of her ultrasounds. I with Dr. Bergella and myself were discussing her timing for admission. So she has her next growth ultrasound on the her 28-week growth scheduled for October 27th. 4 weeks after that will land us the Monday, like her 32-week growth will be the Monday of Thanksgiving week. And she'll be 32 weeks at that time. And she's been totally asymptomatic, no signs of labor, obviously no bleeding. My thought was to admit her right after Thanksgiving, unless anybody had any other thoughts. Obviously, that could change if she has any kind of symptoms of preterm labor, if she had a short cervix on her anatomy, which she doesn't recall being told. But no history of preterm delivery. Is anyone opposed?
You could also measure her cervix at the next ultrasound just to like check
if
you
there's
at that point, and then kind of decide based on that. When I had seen her at for her second opinion ultrasound, I told her anywhere between 30 to 32 weeks, just given that she lives so far, but she's planning on moving actually to Norristown, where her mom lives. So it's a little bit of a still far, but shorter of a distance. But I think like probably based on the next ultrasound. And we can always instead of doing 4 weeks after that one, do it after at like 3.5. So we can have an ultrasound prior and see what her cervical length is at that visit and kind of decide based on that.
Yeah, I feel like that's reasonable. I just kind of wanted to give her like Thanksgiving at home instead of having her spend it in the hospital. Unless we like had a really compelling reason to admit her before that, just to have her like sit until potentially 36 weeks. Is anyone else okay as long as cervical length is appropriate? We'll call appropriate over 2.
I'm fine with that. Yeah.
Okay. Okay, last one is the parvovirus patient. So she is Madison Thompson, 22-year-old. She's at 29 weeks and 3 days. She presented to OB triage with like kind of a viral symptoms, unclear what was going on the 27th of September. Per the H&P there, she noted that she started to feel sick on that Monday preceding, which is September 22nd. So she was diagnosed based off of symptoms, like she had the classic flushed cheeks, so did her child recently, and obviously they're in close contact. And then she had both IgG and IgM positivity, like indicative of a recent infection that was starting to seroconvert. She's scheduled for LabCorp genetic counseling. She's also a CF carrier, and her partner has no testing. There's some extra, tests that can be done from her amniotic fluid sample, with scheduled amnio to follow on the 14th. That will be 3 weeks and 1 day after her infection. The main question is if that amnio is negative, PCR is negative, are we comfortable stopping? And she's scheduled for hydrops checks weekly. No signs of hydrops thus far. Are we comfortable stopping hydrops checks weekly if the PCR is negative 3 weeks after maternal infection? There's very limited data on this, as you can imagine, but there's been a couple case series. I think the last one was published in 2015 that demonstrated that it should be detectable in the amniotic fluid within 2 to 3 weeks after maternal infection. So I suspect it would not become positive after that.
I think that's reasonable.
Cool. Obviously, if it's positive, we'll continue hydrops weekly.
Yeah.
Yeah, I didn't answer because I have to check the data. So
yeah, I can send out the case series I was looking at.
Yeah. Okay, great. Thanks.
Yep.
Thanks.
That's all I have. They're having so much more fun than we are. Yen, do you want to do journal club?
Yeah, I think this is a good time to segue into journal club. Give me 1 second. I have to share window. Oh, God. Give me 1 second. I switched to a new computer, so now everything's a little different. Entire screen. Can I do that? To restart Chrome.
Yeah, and I wonder if you faced your computer like towards the wall at the head of the table, or if you went towards the whiteboard, if we would pick up on less of the noise from the resident room.
Okay.
Just like
All right, guys, bear with me. Bear with me. This I will be able to. Okay, I think I might have to log in and log out for us to. Let me just set this up.
And Lachey, as we're waiting, the MFM from Penn, she would very much appreciate getting your slides. So I'll send you her email for the hepatoma. She wants to educate her colleagues also about it and her IR people. So I'll Sonia also have her email. She's at Penn State. So if we can communicate with her, include me on the email, introduce yourself to her. And I think it's always nice to build connections with other MFMs in the area. So that would be good. Okay.
Yeah, absolutely. I'm happy to do that.
Great.
Can everyone hear me? Okay.
Yes, we can.
Okay, thank you. Okay, so today, so my name's Yen. I want to, for the October Journal Club, kind of want to revisit, a oldie topic, but, a foundation of our care for patients. This comes off the latest clinical expert series regarding sepsis, titled Sepsis and Septic Shock in Pregnancy, that came out in June of this year. The reason why I picked this topic is because, like in med school, graduating med school, we were all given this pocket card surviving sepsis campaign. I think, whenever I'm on call, always, making sure we're screening patients appropriately for concern, because these are pregnant patients, pretty vulnerable, and they can, for lack of a better term, come very quick. All right, briefly, sepsis, number one cause of pregnancy-related mortality, accounts for 24% of in-hospital maternal death during delivery, so up to, a third. And in terms of postpartum readmission, for sepsis can be up to 38%. Estimated to affect 1 in 1,000 pregnancy. Most death is preventable when we have early identification and timely management. Again, majority of all of the etiology would, begins outside of the hospital, emphasizing on outpatient vigilance. I think it's a good, chart to remind ourselves, pathophysiology of sepsis. So first, we have a trigger, which most frequently is infection. The way I approach sepsis is that if you just overreact to have an overreactive, inflammatory response to a trigger. And this manifests its way in 4 different pathways that will eventually lead to peripheral vasodilation that can cause shock. So first is you have increased nitric oxide production and diffuse endothelial damage. You have inflammatory cells that express tissue factor with activation of clots and cascade, putting patient into a prothrombotic state. So we think about DIC. And although we think about, for sepsis, septic shock, with infections, we think about peripheral vasodilation, but we don't forget the component of septic cardiomyopathy that can compound and cause systolic and diastolic dysfunction. And lastly, you have mitochondrial dysfunction that would compromise aerobic metabolism, resulting in your increase in lactate. All of these pathways eventually, present a patient in vasodilation shock, hypovolemia, DIC, and potential addition of the cardiogenic shock of the septic cardiomyopathy that's mentioned here. So what we clinically, we need to recognize is that patient is in a hypoperfusion and end organ damage, can present as severe encephalopathy, acute respiratory distress syndrome, liver and kidney injury, bowel dysfunction, bone marrow dysfunction, and prolonged clotting time from consumptive coagulopathy. So like briefly again, through 4 mechanisms that, have infection that causes a trigger, then we have a dysregulated overreactive inflammatory cascade, that what you end up at the end is decreased systemic vascular resistance. You have distributed shock. Don't forget the septic cardiomyopathy, that now you can have an addition factor of myocardial suppression. And pregnancy physiology can complicate this diagnosis in several pathways. And that leads us, in the next couple of slides, to kind of lead us into, well, how do we best screen for this? What tools out there that are specific to pregnancy? So in normal pregnancy, we do have an increased baseline heart rate, decreased blood pressures in certain trimester. We have an expansion of plasma volume and a baseline mild increase in white blood cell that is normal in pregnancy. A lot of these overlap with early sepsis physiology that could result in delayed recognition if we're not vigilant about patient presentation. Important that fever is absent up to 25% of obstetric sepsis, even in fatal cases. And I think this is an important factor, for our pregnancy populations. outside of pregnancy, we are, typically comfortable recognizing fever as a sign of infection, but we have to keep in mind that a lot of septic pregnant patients do not have this. If patient is on a beta blocker, say, patient also have underlying preeclampsia, chronic hypertension is unmet, this beta blocker can blunt tachycardia as well. If patients have, underlying preeclampsia, this can mask hypotension, relatively underestimate the severity. So it's important to do a assessment that is trend-based and not a single threshold. So what is the trend in, incidence of sepsis in terms of antepartum, delivery, and postpartum? So in antepartum, incidence about 1 in 900 is often community onset. During delivery, we are based on the California data in this CES, we are seeing more sepsis cases occur during delivery, with a trend of intrapartum sepsis. Sorry, this is miswritten there. But in the postpartum period, the rate of sepsis is relatively stable over time. Briefly, I know for our group, we're very familiar with this, but in antepartum bugs that we want, etiology that we want to think about is pyelo, intraamniotic infection, septic abortion, pneumonia. Intrapartum or recently postpartum, we think about endometritis, wound infection, pelvic abscess, neck fash, and less commonly, septic thrombophlebitis, appendicitis, meningitis, cholecystitis. And for us, it's obstetrician always, and intraamniotic infection that can lead to endometritis postpartum. Bugs, we always want to make sure we cover E. coli, GBS, group A strep, high association with actually highest mortality risk. Other bug we want to think about is staph, anaerobic, but also other viral infections, flu, COVID, that should not be forgotten, and other bugs such as Candida. So what makes up the best screening tool? So the aim to, when we're assessing, what screening tool is best to use for our pregnant patient, in this CES, they pointing out that sensitivity should be comfortably above 90 with low false positive rates, and we'll go into each one to see which one we think would meet this criteria. And non-pregnant tools, if were to be used, in certain hospital, need to modification that is, that needs to adapt into the physiologic changes in pregnancy. So the ideal approach is dual screening, where you use your tool, but also the patient's clinical presentation, the trigger in the right clinical setting, and of course, injury markers. So there are a few comparative tools that they included in the CES. The one we'll focus on today would be the pregnancy adjusted, but just, kind of overall picture for sepsis in the sepsis campaign. There are many tools that could be used. For non-pregnant adults, it's the SIRS, and other includes, the National Early Warning Score, the NEWS or the MUSE. I think kind of training from med school, I'm more comfortable kind of recognizing SIRS. And then we're going into, how do we adapt SIRS to our pregnant patient? Now, the more pregnancy adjusted sepsis screening tools out there, so those including the sepsis-associated adverse outcome, or the SAP, the UK Obstetric Surveillance System, the UK OSS, and then we also have the California Maternal Quality Care Collaborative for sepsis. And when we look into, there are even further tools specialized in recognizing severe maternal morbidity screening tools such as the MILT or Safe Mother Initiative. So we're familiar with this because this, we use it frequently here for hypertensive patients. It's really interesting. I won't delve too much on this, but the Heart Safe Motherhood they discuss regarding, the effectiveness in screening in the antepartum period as well. Okay, so before we go into the tools, comparison, again, I really appreciate this article, kind of really pointing out that because of these physiologic changes in pregnancy, using a single tool throughout pregnancy and postpartum might not be ideal. And depending on, how far along the patient is, where we are, in this pregnancy, are we in antepartum, intrapartum, postpartum, we might not be using the same tool. And briefly in here, important factor that all tool uses, heart rate. And I appreciate here that most pregnancy adjusted tool have elevated heart rate threshold. That might not be appropriate to use in early pregnancy or in the postpartum period. Okay, so for SIRS, again, non-pregnant adults. I think we're very familiar with this, right? We have the temperature criteria. So we have a patient presented a temperature below 36 or above 38, heart rate above 90 per minute. Again, we'll see how this is adapted onto the pregnancy adapted protocol. Respiratory rate above 20s and white blood cell above 12,000 or below 4,000. Again, we do see, a baseline mild leukocytosis that is normal in pregnancy. But positive of any of the 2 out of 4 are met is considered to be positive. I'll go a little slower in kind of like the breakdown. So here first we have the antepartum period. We have the delivery hospitalization. This is your induction, your C-section, your immediately postpartum. And then we have a postpartum period that is broken down to 3 days before 3 days postpartum or after 3 day postpartum. And the CES, do a good job at giving us what data out there to combine these study in pregnancy and postpartum. And if you look through it, there's not going to be a lot of study validating these tools, but we do have a few that do. Okay, so first, in the antepartum period, they broke down into before 20 weeks and after 20 weeks. And then we're going to take a look at the sensitivity and specificity. Again, like I mentioned earlier, our goal is to have a screening tool that is above 90. So for the SIRS criteria for antepartum, again, before 20 weeks, we see here sensitivity is 77, specificity is 79. After 20 weeks, the sensitivity go up quite a bit. Now, making this a good contender for screening for sepsis. Sensitivity go from 77 to 92. Specificity dropped a little bit. Taking the same patient now, going through postpartum after vaginal delivery, patient starting having, abnormal vital sign. SIRS is a fair tool because now our sensitivity has gone up significantly above the 90%. But our specificity isn't quite there. At 63, I would say it's, on the lower side. And in the postpartum period, it's interesting how they broke down to the 3 day, postpartum and after timeline here. We see here SIRS perform pretty fairly in terms of sensitivity for postpartum patient with a specificity of 78%. And compared to, kind of a 3 day postpartum patient, I would say the number is approximately the same. We did lose a little bit on sensitivity. So to kind of summarize, this SIRS criteria, we see that SIRS have a range of 92 to 97 sensitivity that can help identify a pregnant patient with sepsis. However, it is limited by a range of 63 to 79% of specificity with a 20 to 37% false positive rate. So, overall might not be the best. So now we transition into a pregnancy-adjusted sepsis screening protocol, screening tool with its CMQCC and the UK OBSS. So the CMQCC, how is this different from SIRS? We have the same temperature criteria, again, less than 36 Celsius or above 38. The heart rate for this tool allow us to now, adapt it to the pregnancy range, which is above 110. The respiratory rate for SIRS was 20. Now with the pregnancy adapted, abnormal is considered above 24. And for the white count, they adjusted the white count to be above 15,000 compared to the non-pregnant adult, which is 12. Positive is the same, very similar, 2 out of 4. So let's see how this performed, throughout pregnancy period. In the antepartum timeline, the CMQCC has pretty low sensitivity, high specificity, but low sensitivity. After 20 weeks, we do see it performs a little better, going from 57 to 81. The specificity stay the same. During delivery, hospitalization, recently postpartum, patient delivered, she's tachycardic, she's bleeding, she had intraamniotic infections coming in. How this patient would perform on this screening tool? We see a significant jump in sensitivity, going to 90.6%, with a pretty significant specificity, 93. Compared to the SIRS here, which also have high sensitivity, but specificity is suboptimal. Now, in the postpartum period, we see similar trend. It performs fair on the sensitivity standpoint. Specificity continued to be high. And up to this point, the CS did not, there's no study combined the pregnancy and postpartum data. The next is the UK OBSS. So here, all of their criteria it's kind of like a transition point between the CMQCC and SIRS. So temperature criteria, again, always the same. This does not change. Keep in mind, 25% of septic pregnant patients don't have fever. The heart rate, they kept it above 100, so same as SIRS. Same as SIRS for respiratory rate. The white count is, the threshold is raised above 17. Positive for any of 2 out of 4 is considered positive. So let's see how does this perform in pregnancy. Antepartum standpoint, the UK OBSS performed very similar to the California metrics. Low sensitivity overall, fair specificity. It performed much better in intrapartum, specifically, delivery, patients still in the hospital, recently from C-section, recently from vaginal delivery. We jumped from a sensitivity of, mid-60 to 92. So this will cross the threshold of what would be considered a good screening tool. The specificity is above 90, making this a very decent candidate for a good screening tool. Postpartum, immediately within the first 3 days, this screening tool is able to maintain, above 90% sensitivity and very good specificity, telling us that this is a good tool for a postpartum patient. Beyond 3 days, both sensitivity and specificity does drop a little bit. I mean, if you think about it, this white count cell, this leukocytosis criteria is pretty strict. So overall, when we compare, the last two, I have a summary slide. But overall, the 2 pregnancy-adjusted sepsis screening tool, the CMQCC and the UK OBSS, have the best balance between sensitivity around above 90, so 90.6 and 92, and low false positive rates, specifically for the intrapartum screening. So to kind of put everything together, we have the SIRS. I recognize I did not go over the QSOFA or the Muse. You can read a bit more in the CS, but they're just not good tool. So with the SIRS, we have good, it has good sensitivity in a patient intrapartum. Specificity, we do have a wide range that is quite suboptimal, starting at 63 to 79. SIRS is sensitive, but it does have a higher false positive rate. The Q-sulfur, the Muse, poor sensitivity, perform very poorly in pregnancy. I don't think we use it here. The Muse, supposedly, in one study showing that has 100% sensitivity, but in others it's 15, so highly variable. This is not a good tool. Now, the screening tool specific to pregnancy is a CMQCC and a UKOBSS. We see here they both have fair sensitivity. Again, anything over 90 is what we want to use. Specificity, they're both, in the 89 to 90, to above 90%, with a false positive rate around 69. Best balance is intrapartum, making these two screening tools strong balance, among all the pregnancy adjusted tools. I'll kind of pause there. Do you have any questions, any comments? The next couple set of slides just mainly kind of
one thing. I don't know if you know, but our fellow Katie Amon, who graduated from here like a year and 3 months ago, her thesis was on CMQCC.
Oh, that's wonderful.
Yeah, so we use it as a tool here for our own patients. That was her thesis, and she published that also. I just wanted to make sure you're aware.
Yeah, that's wonderful.
Thank you, dear.
In the next couple set of slides, I know we're all very aware of management. Just want to highlight, and nothing has changed from the CES.
Yan?
Yeah.
Can you hear me?
Yeah.
Did in kind of comparing the scores, did the SOS, the sepsis and obstetrics score come up, and how it compares to the more pregnancy specific ones like the CMQCC and the UKOSS?
The SAAP, the SAP?
No, the sepsis and obstetrics score. It has like the 6 scoring system with temperature, blood pressure, heart rate, respiratory rate, blood cells, lactic acid, and some other parameters that may not necessarily be addressed in the last two. I was just curious if
Yeah, I can definitely look into that. I don't recall. Is it one of the screening tools that there's on the CES that I don't remember? I mean, I picked out the most sensitive ones. I know the SAAP is not great. That's why I didn't include it. Yeah, no, I can definitely look into that. Thank you. Okay, so kind of going through very briefly again, all of these management is compliance with the Surviving Sepsis campaign. Immediate steps, of course, obtain cultures, lactate, serial trending of your lab. Antibiotics is within hours. I think this is a good point to kind of really, address this to our residents. The number one factor to change outcome in a septic patient is the time from diagnosed to antibiotics. If you ever ask, what do we need for fluids? And you need to emphasize time to antibiotics will change outcome. Fluids can come later. Source control, patients for our population, it's intraamniotic infections and endometritis is what prominence to us most. And simultaneously, fluid resuscitation and hemodynamic support is the goal. Fluid resuscitation, 30 ml per kg, ideal body. Within the first 3 hours, they emphasize here, prefer LR or plasma light. We'll use plasma light here. If you ever get asked, what about normal saline? The association with normal saline, the issue with normal saline is that it's associated with AKI that is induced by normal saline hyperchloremia. It can be used, but if you have LR and plasma light, it is preferred. And of course, from the large study 15 years back, avoid colloids because there's no mortality benefits. And some studies showing that it can be associated with worsening outcome. Assess fluid responsiveness. I think I appreciate also this point in the CES. Never really think about it. For me, you just like get fluids in, get antibiotics in, get everything in fast. But it's good to be mindful of how we assessing fluid responsiveness. Here to highlight, 3 things you can do. First is IVC imaging. I know we don't do it frequently, but of course, if you feel like your patient is not turning a corner, you're managing patient on the floor, can always ask a different specialist to come by and do a bedside ultrasound IVC to make sure that patient is responsive to the fluids that you're giving. Can do passive leg raise. I used to do this back in residency, but they highlight here actually the best way to do this is with a cheetah when you're in like the ICU. But of course, if you have a patient you want to go, fastest is go by bedside, do a passive leg raise and see if they're responding to the fluids you're giving. But the more specific assessment would be with a cheetah machine. Pulse pressure variation concept can also be applied, making sure that patient is responding to the fluids that you're giving. Again, cannot stress this enough. Antibiotics, if you have a source, tailor antibiotics to your source. If not, you go broad. In our field, we cannot miss endometritis, intraamniotic infections, and cover all the bugs. That's pertinent. That's your gram-positive, gram-negative, and anaerobes is what our patients' population have. Don't forget other etiologies such as pneumonia or viral or neck fash. Vasopressor management, if patient is not responding to fluid and MAP is dropping, patient needs to be in the ICU, target MAP is 65 and above. First line is norepinephrine or levofed. It can be started periphery. If your patient is sick and there's no, ICU bed, there might be a delay in time. Always ask anesthesia if they can before you can get the patient there. Second line is vasopressin or if epinephrine that can be added. Avoid epinephrine as a vasopressor because it's associated with increased mortality. Norepinephrine works both in decreasing systemic peripheral resistance, also having effects on beta receptor in the heart. So it can also increase cardiac output. Again, etiology of sepsis, you have vasodilation in periphery, also can have a compound septic cardiomyopathy. So that's why levofed is preferred as first line because you do both in a vasculature, but also on the beta receptor of the heart can increase output. I think they say up to 10 to 15% can increase cardiac output by 10 to 15. If you need to start steroids, again, patients should already be in the ICU. The role of steroid immunomodulator, decreasing the excessive inflammatory response that can lead to multi-organ failure and upregulated the catecholamine receptor expression, leading to a faster shock resolution. Total dose we're looking at should be hydrocortisol 200 milligram per day. Can be done in a few ways. It can be done IV every 6 hours, 50 milligram. The patients in the ICU, a lot of time they just do a continuous infusion. This is something that I would start continue for 7 days. This article kind of wrapped up with post-sepsis syndrome. So it's not just the medical part that we, take care of patients, is what happened after too. I think, debriefing with patient, what happened, how they were managed, can help, help them, psychologically, and also discuss with patient what is the ramification, in the future pregnancies is something that could be recur, things like that. I think a lot of the time it helps patients recover after. In my own practice, I see, some patients have, when on chart review, history of sepsis in the ICU 5 years ago. And when you talk to the patient, it's a big stark contrast to see they really just don't remember much of it. And it's almost like a trauma response, block everything out. Like, oh yeah, that was bad. I'm glad I'm alive. And it's good to help patients kind of unpack, those psychological factors, either with you or with a therapist or a psychiatrist. Screen for depression, anxiety, and PTSD up to 1 year postpartum per the CES. And always refer patients to MFM, follow-up clinic, reviewing the history, debriefing what led to that, outcome and how that could be addressed in future is recommended for these patients. And well, thank you so much. Is there any question? Thank you. Lachey, I'm going to go back to your question. Let me see here if I can pull up that CES. You said there was, for some reason, I don't recall. Let's see here. Which one did you address? Do you want to ask about, Lachey? The SAP?
Or
the mute?
Wait, say that again. Sorry.
Which tool were you talking about?
Oh, the sepsis and obstetrics score. It came up in kind of preparing for the journal club today, and I guess it's, from what I understand, it's more of like determining if the patient needs ICU admission or not, but I'm not sure like clinically how it's applicable compared to the other like pregnancy specific scoring system. So Dr. Bender, Dr. Okwatli, have you guys used this scoring or no? Okay. Thank you.
Yeah. I think the key with managing sepsis is to recognize sepsis, which a lot of the time, I definitely find myself as a resident, like calling, as a junior resident, calling medicine, like, is it sepsis? Is this not? And, I remember 11 p.m., they would tell me, well, what do you have to lose? Sepsis is about recognition. You can always de-escalate.
I think if we are to do a survey, probably we delay its diagnosis, right? So, and this is basically the big message. And there are different tools, and the California one, probably is a good one. I don't think it's implemented universally here for all our patients. But, even when Katie presented her data, when we talked about the heart rate, like being elevated, some attendings were saying, well, why am I going to be worried about a heart rate of 120? But that can be because of pushing. So we had to convince them, a very high heart rate is not necessarily just pushing and labor. And I think we just dismiss some of these changes, as, okay, she's in labor, yeah. She had an unsustained fever or something, but she when the entire clinical picture, she's been ruptured for like forever, like 36 hours, and she had a temperature, but then it defervased while she took like Tylenol for something else, headaches, and then the temperature is gone. So it's difficult. You have to evaluate the entire clinical picture, so. And you have to be on top of this thing because these things can kill patients.
Yeah, I think Yen's point about timely initiation of antibiotics, and if you're not sure of your source, just starting broad is really important, because we're not going to really hurt anyone by doing broad spectrum antibiotics for a short period of time until we know what is happening. So I think that's one place that things get delayed, because we're like, oh, well, what antibiotics should we start? Should we start antibiotics? The answer is always yes and broad. And the second point is that I think we're pretty good in triage about giving like 1 liter of IV fluid, and then they don't get any more fluid. And so we really need to be on top of making sure that the like resuscitation, the antibiotics first, and then that the resuscitation of fluid is actually continuing to occur.
Yeah.
Well, thank you, everyone.
No, thank you so much. And guess what? You guys got an hour and a half of wellness. What?
I said, yeah, short meeting. Thanks, everybody.
Yeah, short meeting. But then the fellows will have a nice break now.
Yeah.
Yeah.
I want to see
Thank you, guys.
everyone else wants to get their cat.
Oh, yeah. Wait, where are my cats? They're dispersed.
All right, never mind. All
Oh,
right, bye
okay.
guys.
You guys,
Bye.
you take care. Bye-bye. Bye-bye.
I still don't know